Assalamu alaikum. My name is Dr. Nadush Bhatt and I am working as consultant gastroenterologist at Jinnah Postgraduate Medical Center and Aga Khan University at Aga Khan University Hospital, Karachi. Today I'm going to discuss with you about the acid peptic disease and peptic ulcer. So acid peptic disease is comprises of few entities which includes peptic ulcer, gastric ulcer, duodenal ulcer, and we use the term hyperacidity and Zollinger-Ellison syndrome. So acid peptic disease can also be uh, considered as acute ulcer. It is also called stress ulcer, and it can lead to chronic ulcers, or it can be present as gastritis. So there are many entities in this word, acid peptic disease. Its incidence, in the next few slides we discuss about its incidence, etiology, clinical presentations, investigations, differential diagnosis, and treatment. In peptic ulcer, around 10% of the population of the world is affected with the peptic ulcer. Gastric ulcer usually occurs in the elderly patients in 5th to 6th decade, and duodenal ulcer is common in adults in the 4th decade. Duodenal ulcer also common in young people due to their irregular eating habits. So duodenal ulcer, it usually occurs in the proximal duodenum, 1 to 2 centimeter of pylorus. It is associated with increase in acid production. And if duodenal ulcers, you find duodenal ulcers in duodenal distal duodenum, the cause may be Zollinger-Ellison syndrome. So this is a picture which is showing duodenal gastric ulcer. This is the gastric ulcer, which is near the pylorus. This is also called pre-pyloric ulcer. And this is the ulcer crater. This is the ulcer crater, and it is covered with slough. And this is the first part of the duodenum, and you can see this is also a ulcer. And this is the endoscopic image. Both are the endoscopic image. In duodenum, ulcers are commonly found in the first part of the duodenum. Gastric ulcers, they are type 1 gastric ulcer, which is most common among gastric ulcers. It is in proximal antrum. It occurs due to decrease in mucosal defense and decrease in acid production. Type 2 gastric ulcers is secondary to duodenal ulcer, and it's sometimes associated with pyloric stenosis due to its closed proximity with the pylorus. Type 3 gastric ulcer, it's a pre-pyloric and pre-pyloric channel ulcer. It occurs due to increased acid secretion, and it's common etiology with duodenal ulcer, usually occurs with the duodenal ulcer. So gastric ulcer, benign versus malignant or carcinogenic ulcer. We always consider gastric ulcer malignant, and we have to rule out, we have to take biopsies from the gastric ulcer, because in stomach, malignant ulcers are more common as compared to the duodenum. So what are the differentiating points between benign versus malignant or cancerous ulcers? Rugae are usually present up to the margins in the ulcer. They are small. Benign ulcer, they are small, less than 2 centimeter. Sticking of barium, if you are doing the barium studies, there is sticking of the barium on the ulcer. There is usually accompanying spasm, and most of the time it occurs due to decreased acid. Cater beyond the normal stomach on a barium study. So these are the features of the benign ulcers. In malignant ulcers, the rugae are short, and sometimes they are small, they are big. Usually they are associated with the conditions like achlorhydria in the absence of the acid, and it's limited to the stomach. Etiology, this is a very common saying about peptic ulcer or acid peptic disease. about the etiology, hurry, worry, curry. So usually it occurs when you take food in hurry, and sometimes it occurs due to stress, full conditions. That's why called worry. And curry is your different type of food, fast food, and different foods which can lead to the peptic ulcer or acid peptic disease. So it's a very common saying about APD, hurry, worry, and curry. Pathogenesis is imbalance of acid pepsin and mucosal defense, which leads to the ulcer. H. pylori infection is the most common infection worldwide, which leads to the ulcer. NSAIDs commonly used for the rheumatological conditions, joint pains, and the overuse of NSAIDs or over prolonged period of time, if you are using NSAIDs, it can lead to the gastric and duodenal ulcers and gastritis. Zollinger-Ellison syndrome, in which there is a hyper secretion of the gastrin, which leads to the increased ulcer formation. And type A personality, again, the worry, which leads to a type A personalities have more worries, they are more overthinkers, so they lead to the ulcers. H. pylori is a cause of 95% of the duodenal ulcers. 80% of the gastric ulcers are also caused by the H. pylori. It leads to the decreased mucosal resistance and hydrophobicity, and eradication of H. pylori reduces ulcer recurrence. So according to the guidelines, whenever you come across with duodenal and gastric ulcer, you have to eradicate H. pylori with the standard H. pylori eradication treatment. Few words regarding the diagnosis of the H. pylori. So H. pylori can be diagnosed with 95% of sensitivity with urea breath test, and you can use stool H. pylori antigen test or through endoscopic mucosal biopsy. People are the general practitioners usually advise patients antibody tests, which are now obsolete. So don't go for the H. pylori antibodies test. Always advise your patient about the urea breath test for the H. pylori, stool antigen for H. pylori, and biopsies. And in cases of ulcer, you have to eradicate the H. pylori. NSAIDs, it leads to they suppress the prostaglandins, and in return, prostaglandins decrease acid secretion, increase mucosal blood flow, increase mucus and bicarbonate secretion. This is a function of the prostaglandins, which is suppressed by the NSAID. So 10 to 30% of in NSAIDs leads to the in chronic uterus leads to the ulcers. Zollinger-Ellison syndrome, it's a recurrent, recalcitrant, resistant, and usually it occurs on unusual sites like in beyond the first part of the duodenum. You can find ulcers in beyond the first part of the duodenum. They are multiple, and they are sometimes they are malignant also. So it affects the 0.1 to 1% of the peptic ulcer, type 1 and type 2. Gastrin secretion from non-beta cells tumor of the pancreas, which is called gastrinoma, which leads to the Zollinger-Ellison syndrome. So if you find ulcers beyond first part of the duodenum or multiple ulcers and recurrent ulcers, so you have to rule out gastrinoma or Zollinger-Ellison syndrome in the patient. The common sites for this gastrinoma is pancreas, duodenum, and antrum. So 20% in cases it is multiple. In 66% of the cases malignant. It's a slow growing indolent tumor. Parietal cell mass is increasing in the ZD syndrome, and there is some genetic basis in its pathogenesis, and it leads to massive hypersecretion of the acid. So the main stay of the treatment is proton pump inhibitors. Sometimes Zollinger-Ellison syndrome is associated with MEN1, hyperparathyroidism, islet cell tumors, and pituitary tumors. So duodenal ulcers, again, it can be due to NSAIDs, acid hypersecretion, rapid gastric emptying, impaired acid disposal, and smoking. So there is increased secretion of acid, Gastric ulcer again, H. pylori, NSAID, duodenogastric reflux, impaired gastric mucosal defense is also one of the causes of gastric ulcer. So acid secretion is normal to low, reflux of duodenal contents, which leads to gastritis and ulcer. Pylorus sphincter disorder may be a cause, which leads to reflux of the duodenal contents into the stomach. Smoking, disturbed mucosa with low-grade gastritis. Clinical presentation, duodenal ulcer in usually is pain relieved by food or alkali, and it causes pain several hours after meal. Gastric ulcers, gnawing or burning pain on eating. So there is a difference. In duodenal ulcers, pain relieved by food or some alkaline foods, and pain aggravated after few hours of meals. But in gastric ulcer, the pain started just after taking the food. So this is the difference between peptic and the duodenal ulcer on clinical presentation. Periodic chronic recurrent pain, it can lead to nausea and vomiting, weight loss, epigastric tenderness. Investigations, endoscopy has 90% sensitivity and must be in all patients with severe pain. You have to exclude malignancy in your patient if they have recurrent symptoms or their age is more than 50 years of age, and or if they have some red flag signs like weight loss, hematemesis, hematochezia, stool focal blood positive. So you have to rule out through endoscopy. Biopsy can be taken, and we usually take the biopsies, and you can take the biopsies for H. pylori, which is a gold standard. So ulcers, which is present in the stomach and duodenum can be classified according to the Forest classification. So this is the Forest classification you can see. So there is a stigmata of hemorrhage. So you can classify according to the stigmata of hemorrhage. If there is active spurting bleeding, it's 1A. If active oozing bleeding, it's 1B. If there is non-bleeding visible vessel at the base of the ulcer, it is 2A. If there is adherent clot, it's 2B. And if there is a flat pigmented hematine spot on the ulcer, it is 2C. And clean base, which we have shown in the ulcer like this, is Forest class 3. So major stigmata, non-bleeding blood vessel, you can appreciate in this picture. This is the adherent clot. There is a role of endoscopic therapy of ulcers with adherent clot. You can remove the ulcer and you can treat the underlying lesion. This is the Forest classification 3. It's a clean base ulcer, and this is a hematine spot. Endoscopic hemostasis, you can inject epinephrine injections, you can apply thermal coagulation, or you can apply mechanical hemoclips for the management of acute bleeding from the ulcers. Usually we use combination therapy because it's superior than the monotherapy. So H. pylori I already discussed. It can be detected with blood tests. Blood test is obsolete now, and tissue test. Differential diagnosis, in all the symptoms, if your patient is presented with upper abdominal pain, you have to rule out cholecystitis, hiatus hernia, pancreatitis, myocardial infarction. This is very important because many people rush in emergency due to vomiting and epigastric pain, especially elderly diabetic patient, but they have myocardial infarction instead of peptic ulcer or gastritis. Basal pneumonia can present with epigastric pain, vomitings, and other symptoms, dissecting aneurysms, worm infestation. So you have to rule out all this. Treatment, number one, you have to stop the factors, precipitating factors. So stop smoking, NSAIDs, alcohol. Antacids are good, they are used for the acid neutralization, but they are not the treatment. H2 receptor antagonist, ranitidine is commonly used. H2 pump inhibitors, commonly used omeprazole, anticholinergic secretory inhibition, and misoprostol, it causes mucosal protection. There are different proton pump blockers are available in the market. You can use them in patients. It depends on the physician choice, or sometimes one type of omeprazole one type of PPI suits better to some patient, and some patient suits with esomeprazole. You can give different PPI to the patients according to your choice and your patient's choice. Sucralfate is a protective coating you can give your patients with ulcers, and you have to eradicate the H. pylori, and their standard H. pylori regimes. Duodenal ulcers are 95% control with medical treatment. Surgery is now outdated or obsolete. Omeprazole is better than ranitidine or H2 receptor blocker. Ulcers heal in 80% by 6 months, decrease recurrence in 95% in patients if you give H. pylori eradication. Indication of for surgery is only in cases of complications like hemorrhage, obstruction, and perforation. Otherwise, there is no role of surgery in the treatment. Duodenal ulcer, H2 receptor blockers heal 75% of duodenal ulcer in 4 weeks, but we are not giving H2 blockers nowadays for the treatment of duodenal ulcers. PPI is better, it has better results. So when you have a drug available in the market which has superior results, then go for that drug. Ulcer may recur in 80% of cases on stopping again treatment of the H. pylori. So you have to give in gastric ulcer, you have to give omeprazole or H2 receptor antagonist at least for the 8 weeks. If pain not relieved by 2 weeks, add one more drug. Repeat endoscopy after 8 weeks if patient don't not responding with the treatment or have some red flag sign. If no healing by 12 to 115 weeks, first you have to take the biopsies. If biopsies show some malignant thing, then you have to go for the surgery. So distal gastrectomy with vagotomy or gastroduodenal or gastrojejunal um, interposition. You can go for proximal ulcer, and you can go for total gastrectomy. Hemorrhage is a potential cause of death. 15 to 20% leads to gross bleeding. It usually occurs with the erosion of duodenal ulcer into the gastroduodenal artery. So we already discussed you can give adrenaline, APC, or thermal coagulation. Perforation occurs in 5 to 10% of cases, but now its incidence is decreased markedly due to the advent of the new drugs. It can lead to the pneumoperitoneum in 75% of the cases, peritonitis, pain and ileus, leukocytosis, hypovolemia, third space loss. Differential diagnosis is acute appendicitis and enteric perforation. Obstruction, chronic ulcer disease with edema and scarring can lead to obstruction in 5% of cases of duodenal ulcer. It can present with a gastric outlet obstruction, and patient presented with nausea, vomiting, and abdominal distension. Sometimes it leads to metabolic alkalosis and paradoxical aciduria. So these are the uh, few slides regarding the acid peptic disease and duodenal and gastric ulcers. Thank you.